And now I'd like for you to consider for a moment a common, multi-complex patient, a patient with multiple medical comorbidities. Not an out-of-the-ordinary patient, but one you have definitely seen in your clinical practice and will see again. Mrs. Colon presents to your clinic for her semi-annual checkup. She's a kindly 87-year-old Hispanic woman of Puerto Rican descent, English and Spanish speaking, retired, widowed, and living by herself in a fourth-floor walk-up apartment in Brooklyn, New York. And this represents many of the patients we see aging in place here in New York City, aging into environments that were quite healthy when they were younger, but maybe a little more difficult as they age. Her past medical history includes hypertension, hyperlipidemia, congestive heart failure, type 2 diabetes, osteoarthritis, osteopenia, falls, 2 falls in the last year, mild cognitive impairment, no past psychiatric history, and she's had both of her cataracts removed with lens replacement. She's had total knee replacement on the right side. She has a family history of diabetes and myocardial infarction. So far, we definitely meet the criteria for multi-comorbidity, and these are her current medications. Metformin, insulin glargine and aspart, carvedilol, furosemide, atorvastatin, alendronate, acetaminophen, ginkgo biloba, and aspirin. And you should start to be thinking already, as we're looking at this, how she fits into the 4Ms model. How are we doing medication-wise? Is she experiencing polypharmacy? Are any of these meds high risk for older adults? Is there anything that might be eliminated or improved or optimized? And yes, she is experiencing polypharmacy by the most standard definition of being on 5 or more medications, which places her at all sorts of risks, including increased risk of adverse effects and, of course, increased risk of falls. And we already know poor Mrs. Colon has already had 2 falls in the past year. Mrs. Colon was born in Puerto Rico and she has 5 siblings, unfortunately 4 of whom are deceased. She was married for 60 years, but unfortunately also has been widowed for these past 4 years. She has 3 children, all living in New York City, which is great, right? Potential source of support. She was a retired nurse, Catholic, attends church weekly, but doesn't attend a senior center, so she's modestly connected to the community at large and hopefully to her family as well. And I would add a bit about her personality. She's a fiercely independent woman, highly intelligent retired nurse who really wants to have full control of her care and to remain in her home environment as long as possible. Substance history-wise, no cigarette use, thankfully, but she does drink 2 to 3 glasses of wine per day, no drug use. And at this point, we don't know what 2 to 3 glasses of wine means for Mrs. Colon. Does that conform to my definition of 2 to 3 glasses of wine, or is it her own definition? But we're starting to get a little worried at this point, considering her history of falls, and also in combination with her polypharmacy and alcohol consumption. So let's pause for a second and have another brainstorm. What are your thoughts so far about the complexity of this patient, Mrs. Colon? How would you manage her care in your current clinical environment? Could you manage her care? Are you operating by yourself or do you operate in a team? Would you need to make referrals? And what referrals would you need to make? What would be the ideal model of care for Mrs. Colon? Pause the video for a minute and write down your answers so that we can discuss them when you come into clinic.